the HPV vaccines, cancer cervix, contraceptives, anemia in pregnancy, and the like preventive obstetrics, which covers the MMR, IMR, perinatal mortality, antenatal visits, about iron folic acid requirement, then MTP-ET, etc.
All the topics will be covered. Let's start the journey with this first question, which is on HPV vaccines, and it is based on which viral protein. So there is two question which came on this topic. One is which viral protein they are using. So they are using the longer one, L1 and L2. L1 is much better answer. And in the second question, they have asked that which of the following viral protein is a marker for high risk of cervical cancer. So if you find E6 and E7, then that is the viral protein which mark high risk of high probability of having cervical cancer. And this is what ma'am is going to explain, that how this process of cervical cancer.
HPV virus, which is a DNA virus, this virus gets sexually transmitted. So early age at coitus, multiple sexual partners is a very big risk factor for HPV transmission. And the most common variant of HPV virus that has a role in causing, and this is a proven for cervical cancer, and that is HPV 16 and 18. Yeah. So this majority of the females, around 80% of the females get HPV infection, and our body clears out 99% of infection. If the 1% it persists, this DNA of the HPV virus get integrated into the host cells, that is the normal cervical epithelial cells, and there is replication of viral oncoproteins. Mind it, oncoproteins means which are a risk factor for changing the cell or using the cell machinery. Two reasons: one, for replication of the viral particles; number two, that causes changes in the genes which are cancer protective. So the replication of viral oncoproteins causes the dysplastic changes, that is a pre-cancerous condition which we call it as CIN or dysplasia. And which are the proteins that my friend is going to focus, like E1, E2 where you have to mark, and E6, E7 where you have to mark, and L1, L2.
So E1, E2 is for replication, E6, E7 is the marker for high risk of cervical cancer.
Now, next question I will take up. This is a very, very important question, and the question is, all of the following are screening methods for CIN, that is dysplasia, cervical intraepithelial neoplasia, which is called as dysplasia. Dysplasia is a pre-cancerous condition, and there is mild dysplasia, moderate or severe. Severe we say is CIN3, which has more chances of progression to cervical cancer, and nearly the incidence is near about 22%. There is a risk of transmission to cancer. Now, which of the following are the screening methods except? So the options given to us are pap smear, HPV DNA testing, colposcopy, VIA or VILI. Now, what is VIA? VIA means visual inspection under acetic acid. Visual inspection under acetic acid. What percentage of acetic acid is used? It is 3 to 5% acetic acid. Now, what is VILI? VILI is visual inspection under Lugol's iodine. Okay. As a gynecologist, the screening test which is being followed all over India is the pap smear test. This is a screening test, and the starting age for pap smear screening is 21 years of age, but mind it, it is to be done in sexually active females, and pap smear has to be repeated If it is negative, pap smear has to be repeated every 3 yearly till the age of the female is 30 years. Then it is repeated 5 yearly along with HPV DNA testing. If negative, it is to be done till 60 to 65 years of age. Okay. But HPV DNA is a costly test, and mind it costs around 3,000. So many females may not be opting because of the cost. So an alternative is starting a pap smear test from 21 years of age in a sexually active female. It should be done 3 yearly till 60 to 65 and stop. Now, in WHO has given a guidelines like 90% of the females in India should be, or any country, they should be vaccinated. So girls should be vaccinated. 70% of the female should be screened, and 20% should and 90% should receive the treatment if detected for cancer cervix. So 90, 70, 90. And this guidelines is for eradication of cancer cervix. The data is very alarming. In India, every 8 minutes, one female death occurs from cancer cervix, which is very alarming. Many of the countries, they have included the HPV vaccination in their national immunization schedule, but for our country, the cost is the biggest risk factor. Now, HPV DNA testing is also a screening test, which I have just said. VIA Willy is for mass screening. Can you throw some light on this VIA and Willy?
There is one line question which has been asked from here, that what is the most cost effective way? And Park has controversially written that VIA Willy is the most cost effective because it is very low cost. So most cost effective if they ask for screening VIA Willy, but if they ask best test for screening, of course the answer will be pap smear.
Pap smear.
And colposcopy is not for.
Colposcopy is a confirmatory test. Colposcopy is a confirmatory test. So the answer to this question is colposcopy. So pap smear, HPV DNA testing, VIA Willy. These are the screening tests for dysplasia and cancer cervix. Colposcopy is a confirmatory test.
Let's see the images.
So
which
VIA and Willy. VIA, that we apply the acetic acid onto the cervix. We as a gynecologist mostly take pap smear, but this is for mass screening, and we can train the health worker and they can do the mass screening in the larger population. Okay. So when we apply the acetic acid onto the cervix, the abnormal cells have abnormal proteins, so they appear as aceto white areas. This is abnormal. Now Willy is Lugol's iodine is applied, and normal epithelial cells of the cervix contain glycogen. So they take up the brown stain. So the normal cells, they take up the brown stain because they have glycogen content. But whereas abnormal cells, they have outgrown their blood supply and nutrition. So they do not have glycogen. So they appear as yellow areas. So if this testing is done, but you should have a good white light source to do the visual inspection. Now, if there is any abnormality detected by this health worker, they can always refer that female to the higher center for further evaluation of the case. Now, I just mentioned about 90, 70, 90. This is for eradication of cancer cervix. So many of you students, this might be a new word for you, cancer cervix eradication. This is possible by vaccination, screening, and that is early detection and treatment of cases. Now from my colleague, I have one question which many of you are having confusion, that is the pap smear test belongs to which level of prevention? Primary, secondary or tertiary?
So of course, primary is done when the risk factor is present but disease is absent. Like vaccination is primary, which we can do in Indian guideline from 9-year to 14-year female girl child in all the government schools. They will get one cervical cancer vaccine 9 to 14 years. So that will be primary level. In secondary level, we have screening and early screening and treatment come under secondary prevention. And pap smear is screening, so of course it will be under secondary. And tertiary is for rehabilitation, that means making the person self-dependent, and prevention of disability, that is disability limitation. So like for example, the glasses which some of us wear for refractive error, glasses is not treating the illness, it is making us self-dependent. So glasses will be tertiary, but LASIK surgery, which is treating the refractive error problem, is secondary. So early screening and treatment will be secondary, but if we are doing something for making the person self-dependent, that is tertiary. For example, hearing aid will be tertiary and cochlear implant, which is the treatment, will be secondary. So pap smear will come under secondary. And ma'am has given this question again, which
This
came in
image
INI-CET exam. Yeah.
came in INI-CET exam, that this image which is showing the instruments, now what is this used for? Can you write the answers in the chat box?
And
I'm seeing a lot of chat by the students and they are writing very, very correct answers.
yes.
So what is this instruments shown in this image? And we are taking up the latest pattern of INI-CET. And friends, this session is going to be useful for those who are going to write May 2023 INI-CET exam. This session is useful for those who are going to write UPSC CMS exam, as well as this session is useful for those who are going to write FMG exam. Yes, Dr. Rahul has written very correctly. It is pap smear. Very good. This is what is an Ayer's spatula, and this is a cyto brush. This is used for conventional pap smear. That is a slide method. We take two samples. One is from the ectocervix, one is from the cervical canal. We rotate to 360 degrees the Ayer's spatula, take a slide and fix it with a cytospray. What does cytospray contains? Cytospray contains 95% ethanol plus ether.
Oh.
Okay? This is very, very important composition. Then, you know, like cyto brush, we put it in the cervical canal, and this is for screening of adenocarcinoma. So two cancers we are screening. Now, what is the most common cancer? Cervix is squamous cell carcinoma arising from the junction of the columnar epithelium meets with the stratified squamous epithelium, that is a squamocolumnar junction or transformation zone. Now, what is this spatula? This spatula is for liquid based cytology. Liquid based cytology. This spatula is there and there is a bottle. So we take the smear from this spatula and put that spatula in the bottle, which already contains a fixative material. So if you compare the results, it was said that conventional PAPs से ज़्यादा better है liquid based cytology, but most of the labs are very well sophisticated labs. So liquid PAPs के results can be compared with the conventional pap smear.
But better is
a liquid based cytology. Most of the places the liquid based cytology is being done. Now taking one more question which is very important, that screening for cervical cancer is done in which age group, and I think from the previous question discussion, I hope it is clear to everyone. So you can write your answer. What is the correct answer? Less than 21 years, 21 to 65, more than 65, any female in reproductive age group, or female having multiple sexual partners. So friends, when this question came, majority of the students have written like female having multiple sexual partners. Of course, that is a risk, but pap smear is to be done routinely in all sexually active females because it is a universal screening test. And my friend is going to emphasize what is the most common cancer in female, in world and in India. What is that?
Whether it's India or it's world, in both the cases, our answer will always be breast cancer. Please do not mark cervical cancer as most common cancer in Indian female. Why breast cancer is the answer? Because we all know breast cancer can be diagnosed early, and if it is positive for HER2/neu2 receptor, then we can make the patient survive for 10, 15 year, 20 year also sometime.
Yes.
And there is a very famous formula from which question also comes, that prevalence of any disease, prevalence means old plus new case at present moment, total case at present moment. This is equal to incidence, that means new case multiplied by duration of disease. So, because the patient of breast cancer will survive for longer duration, so at any moment of time when you will count all the old plus new case, that will be very high. That is why, due to this formula itself, breast cancer is most common in this case. Similarly, if someone asks you what is the most common cancer of world, both male and female, again the answer will be breast cancer. Sorry, I did not ask it from you, because many of us think lung cancer will be most common cancer of the world. But again, lung cancer will be diagnosed late, and within 2-3 years of diagnosis, mostly the patient die. So lung cancer will have less duration, and because of less duration, at any moment of time, their patient will be less. So due to high prevalence, breast cancer is most common cancer of the world, both male and female, most common cancer of Indian female, most common cancer of female of the world. Now, when it comes to most common cancer of male of India, can you give the answer? Most common cancer of male of India. What is the answer? Indian male, most common cancer. This has been asked already. And most common cancer of male in world. There is 2 different answer to this question. Please do try. And very good, Kishore Kumar was right in answering that breast cancer is most common in both male, female and the world. Monk, Dr. Monk has answered it correctly. Most common cancer in male of India is oral cavity cancer.
And can you tell what is the most important risk factor associated with cancers in male and female? Single most important risk factor which you find it everywhere. Can you tell, can you write the answer? Because this is very, very important.
Yes.
And this is highly preventable. People think 90%, if it is being traveled, we will also get cancer. But that is wrong. 90% are the environmental factors, friends, and that is man-made. Only 10% cancers are genetically transmitted, like BRCA gene, like Lynch 2 syndrome, and etc. So, yes, Dr. Monk, instead of writing smoking, tobacco is the correct answer. Any form of tobacco, whether it is smokeless or whether it is smoking.
I was wrong.
Oral का जो है वो main जो है, that is our tobacco chewing. Even the form of smoking is the hookah, bidi, cigarette. Okay, and even the e-cigarettes are dangerous because they contain chemicals which are carcinomatous. So this is highly preventable. And let me tell you, alarming data from the various cancer institutes is that 40% in the males, the cancers are associated with the tobacco, and 20% of all the cancers in the female is associated with tobacco. Now, the important factors, environmental factors which is associated with cancers and it is highly preventable is the tobacco, alcohol, obesity and sedentary lifestyle. Please do remember, this is very, very important. What are the environmental factors or the risk factors which are man-made factors and that is responsible or associated with cancer is tobacco, and in tobacco smoking or smokeless comes, then alcohol, then obesity and sedentary lifestyle. Okay?
All present.
All present. Okay. So what is the answer to our question, Dr. Ashwani?
Yes, I think it is 21 to 65 years.
Yes, 21 to 65 years is the correct answer to this question. Now here I would like to add, and it will be associated with PSM as well. Do we have any screening test routinely for ovarian cancer or endometrial cancer, like we have a cancer cervix? And why do we have a screening test in cancer cervix? This is really, really helpful for your Viva questions as well, those who are studying in the final year. Now, what is that? We do not have, and WHO or Government of India do not recommend any routine screening for endometrial cancer or ovarian cancer, because we don't have a simple screening test. If there is any high risk, then we can do certain tests. If there is a risk factor like any gene like Lynch 2 syndrome, or like any gene like breast and ovarian cancer gene, that is BRCA1 and BRCA2 gene mutations, okay, then we can go for a TVS plus CA125 testing in the female, where we want to check for the ovarian cancer. Okay, but routinely nowhere endometrial and ovarian cancer screening is recommended. So why we are doing a cervical cancer screening? Because it is highly preventable, and this is the only cancer where vaccine is available. We will be talking about what is the recommendation for vaccine. We will be talking about Gardasil 9 vaccine which is available in India. What are the strains which is important?
Okay, so we already discussed it. In the primary prevention, we are giving the vaccine in 9 to 14 years. This is already implemented in Government of India guideline. So this is for primary. For secondary, from 30 year of age and 25 year of age with women living with HIV, we are doing screening. This is from Park textbook, this table. And tertiary prevention, we are doing the treatment of invasive cancer, surgeries and all. And ma'am was about to tell that strains. So let's have the strain discussion here.
Yeah, and one important thing, many times a question has come on what is the HPV vaccination age. According to WHO, it is 9 to 26 years of age. And what is the ideal age group for vaccination? It is 11 to 12 years. So we say girls should be vaccinated. What are the cancers where HPV is a risk factor, is a proven risk factor for cancer cervix, and this will protect her from cervical cancer as well as vulval cancer. So HPV is associated risk factor in cancer cervix. It is proven, and it is HPV 16-18. For boys, boys also needs to be vaccinated because there is a risk for penile cancer, risk for anorectal cancer, and risk for oropharynx cancer. Okay, like Gardasil. You know Gardasil, it is HPV.
Gardasil is guarding from all 4 directions. So Gardasil, in the older time, it is quadrivalent Gardasil. And as ma'am was saying, this question has also come that which is the most common strain. HPV 16-18 is most common. So Cervarix has only 16-18. But in Gardasil we have, it's okay ma'am, it's working. You can tell me the strain, I will write it. HPV 16, HPV 18 will always be there.
And HPV 611.
HPV 6 and HPV 11.
6 and 11, what does it cause? It causes genital warts. Okay?
Okay.
It causes genital warts. Okay?
And if you add 6 and 11, it will become 17. So you can remember it like 16, 17, 18, the time when you were in class 11, 12th. Or just past it when you had your first, second or third
now,
crush. That is
FDA recommends the vaccination 9 to 45. Now, if there is a married female or a sexually active female and she comes and she says ki I want a vaccine, what should be your best answer for her? What should be your best answer for her? I would say she should go for pap smear plus HPV DNA testing every 5 yearly. Okay?
So, if what was the question, ma'am?
The question was, if a married female comes and her age is suppose 30 plus, so what should be done? We should go for a pap smear and HPV DNA testing. Vaccination will not help because once she's sexually active, she's already harbored the virus. Now, my more question is why we should vaccinate. The ideal age WHO has recommended is 11 to 12 years. It is for two reasons. 11 to 12 years age. Why it is ideal age for vaccination?
At that time, they are not sexually active 100%. So
One reason.
One reason.
Number two or main reason is this time when you introduce any antigen, the antibody response to that antigen is at its peak. So फटाफट से antibodies बनती हैं and that is what
Quick
we want.
antibody response.
And number three reason is the cost. अगर आप less than 15 years देते हो vaccine, then 0 and 6 months. Like today you have given and next dose is 6 months. That's all. If more than 15 years, the dosage schedule is 0, 2 and 6 months. One more thing, Gardasil 9 has also come and we are promoting plain Gardasil. ऐसा नहीं है किसी को favor कर रहे हैं because cost is a factor. Gardasil 9 is costly and it is costing around 10,000 rupees per dose.
Huge
Okay.
money.
Huge money. So it is against HPV 6, 11, 16, 18, 31, 33, 45, 52 and 58. This strains is very, very important because in a DNB exam, the question was already asked. Okay. Now let us take up this question. This is a very, very important question of NEET PG, DNB, INI-CET and students have lot of confusion in this question. A pregnant lady has a history of delivering twins. One delivery of twins has occurred. She is pregnant for the second time. So जब भी pregnancy आता है तो gravida आ जाता है. It includes the stillbirths, live births, abortions, MTP, ectopic pregnancy, all. Okay. So she is second time pregnant and she has twins. So that means live issue is 2 and number of delivery will be 1. Now students have a wrong in marking, like they write like P2 या delivery तो एक ही हो रहा है ना, live babies are 2, twins are delivering. So that is what it is, G2, P1 and L2. And I can see Dr. Shubham, Dr. Rahul, they have written correctly. Dr. Shubham has marked the strains of the Gardasil 9 also very correctly. Dr. Shubham has written very good, like very, very correctly you're writing. HPV plus pap smear every 5 years, very correct. Dr. Monk is also right. HPV 16 is the most, like common cause for cancer cervix, but most malignant is HPV 18. And one more thing you should remember, this is from our Novak's cancer textbook of gynecology, that HPV 16 is for squamous cell and HPV 18 is for adenocarcinoma. So I hope this question is also clear to you.
When ma'am asked this question before the session to me, I also answered G2, P2, L2. I was also wrong there.
So I hope this is, like you have corrected yourself. Okay.
Okay, so this is based on the syndromic approach that.
And this has come in the recent INI-CET exam. It was coming in the previous exam. It was coming in NEET PG. It is a repeat question every time. So we may expect this question this time again. This is from RTI or that is reproductive tract infection or from sexually transmitted infections. Okay. So.
And sometime you get a logo based question also. And there is 2 type of logo which is being given. One is this, sorry, I am drawing it well. Let me draw it well. This is one logo with a central hole and this is second logo. So what is this logo they ask? And sometimes we wrongly think it as Red Cross. This is not Red Cross. This is Suraksha Clinic. And Suraksha Clinic is using for treatment of reproductive tract infection or
sexually
STD.
transmitted infections.
RTI or STD. Okay. And this is the logo of Red Cross. And Red Cross have their headquarter in Switzerland along with headquarter of WHO, International Labour Organization and UNAIDS. Along with that, Red Cross. All 4 have their headquarter in Geneva, Switzerland. Okay, so these are 2 different things. Now, in this question, coming back to the question here,
Yeah.
they are asking that there is a vaginal discharge and there is no history of itching. There is a history of itching. Okay, present.
So we want to discuss it in two ways because it was prepared with the memory of the students who have written the given the exams. So we got two ways. So we will discuss both. If there is a history of foul smelling vaginal discharge, history of itching at vulva, first speculum examination shows strawberry spots. So what do you suspect? What type of infection it is? It is, like trichomoniasis, because the most common, symptom is itching. There may be strawberry spots, that is very, very suggestive. Okay. And it is an STD, it is a flagellated microorganism, it is a protozoa, and we can see it under saline microscopy. So it is sexually transmitted, so you need to treat the partner as well. This is again very, very important. Need to treat the partner. So what is the color code of the kit? If suppose we go by the PSM or community medicine where a health worker is sitting, okay, then or a nurse is sitting, then they don't know so much of details. So that is what is the NACO introduced a color code kits for them. At least minimum investigation and treat your patient. Okay, before there is a poor compliance. She doesn't want to go to the doctor. Poor compliance. She doesn't have a time. Okay, so which color code kit you will recommend in this case? That is what is the question.
I think they have given the answer, but there is some confusion. Some students are writing gray, but most of them know that it is because there is vaginal discharge.
So it is vaginal discharge. So we think of a vaginitis. So it is green color kit. If suppose the question says cervical erosion or there is a mucopurulent discharge coming from os, then we suspect it is a gonorrhea infection or it is a chlamydia infection. Now, which of the infection cannot be picked up on saline microscopy? So the answer is chlamydia. Chlamydia only you can see the cultures. But हमें culture और इन सब में जाना नहीं है. If there is a cervical erosion and the discharge is coming from the cervix on per speculum examination, then your answer will go for gray color kit, which contains azithromycin and cefixime. Azithromycin is a drug of choice for chlamydia and cefixime will cover the gonorrhea. तो हम दोनों को treat कर रहे हैं. ठीक है. Vaginal discharge में sacnidazole है, which is covering the trichomoniasis and bacterial vaginosis, but mind it, bacterial vaginosis is not STD. ठीक है. And fluconazole is for candidiasis. तो हमने सारे ही treat कर रहे हैं. Candidiasis, trichomoniasis and bacterial vaginosis. If a patient comes with lower abdominal pain, तो हम क्या सोचते हैं? PID. PID, what is the most common causative agent? Chlamydia. What is the next causative agent? Gonorrhea. And next is bacterial vaginosis. ठीक है? Bacterial vaginosis. ठीक है? Bacterial vaginosis. तो उसमें हमें cefixime दे रहे हैं गोनोरिया के लिए. Metronidazole is for like bacterial vaginosis and doxycycline BD for 14 days is chlamydia. So if you go by NACO guidelines, minimum investigation and give the treatment. If you go for a CDC criteria, Center for Disease Control, then again these antibiotics are recommended. We should give the coverage for 14 days, metronidazole and doxycycline for 14 days BD dosage and cefixime single dose for treating gonorrhea. तो आपने सारे organisms you have covered. Now switch over to sir.
Yeah, because they are asking it again and again. Sometimes we get confused between gray and green. Remember, gray is the most common color of the people. We are not good or bad. We are in between. And we start with gray because it is most common, like 3 illnesses have gray. They have asked already: urethral discharge, anorectal discharge and cervical. All 3 are gray. Then second is green. After gray and green, we can remember the things by the simple mnemonic WBR, like white blood cells, similarly WBR. So all the 3 are for genital ulcer. White we use for bacterial ulcer, which can be treated with penicillin. But many people are allergic or they can have anaphylactic reaction from penicillin. So in those cases, we use the blue one where we give doxycycline in place of penicillin. And then the red one is for viral genital ulcer. So we treat with acyclovir. Now, ma'am was saying that yellow we give for lower abdominal pain, of course. That is
PID.
correct. Plus, along with lower abdominal pain, sometimes they ask the question that female come with lower backache. Again, lower backache or lower inguinal pain, both suggestive of PID.
PID only.
Because in PID, infection go to pouch of Douglas, which is the most retroperitoneal structure. And because it is in the pouch of Douglas, so it causes pain in the back area and the lower inguinal areas also. And because it is in pouch of Douglas, so we need a treatment of longer duration of 14 days. That's why we are using Doxy and Metro for 14 days, twice a day. And last is inguinal buboes, treated with black. So WBR, and then start with gray, most common color, and that is there. Yeah, that's what I wanted to add. You want to add something?
That's okay.
Yeah, so coming on to the next question. Which of the following is correct for public-private partnership part in Suraksha Clinic and mobile medical unit? So this mobile medical unit, Suraksha Clinic, both are example of public-private partnership, and in both of them, we have the medicine coming from the government always. So medicine always come from government. Now the ambulance or the building cost, in case of mobile medical unit, you have the ambulance, and Suraksha Clinic, you have the building. That can be private or government. But medicine is always from government. Medicine and ambulance both are from government is wrong. Medicine from private is also wrong. And medicine and ambulance both are from private is definitely wrong. So correct answer is of course A, that medicine
comes from government
side.
This is very important because Suraksha Clinic, there is 1 or 2 questions definitely being asked whether you consider it in gynae or in dermatology or in PSM.
all three.
Actually PSM mein to aata hi hai because they are the ones which are giving us the guidelines. Okay. So let us take up something from, like we have covered up cancer cervix, important points which are integrated with gynae and PSM. We covered with, like STDs. Now let us talk about something related to obstetrics, which is again very, very important, and it is very confusing question. So that is why I have added up, and we have added up this question. Minimal antenatal visits in pregnancy, okay, according to WHO and according to Government of India, 8, 6, 4 and 2. According to WHO, the standard they have recommended is minimal 8 visits to reduce perinatal mortality, which is high in India. Okay. Government of India, minimum 4 antenatal visits. First visit, second visit and 2 visits in the 3rd trimester. First visit in the,
Yes,
Dr. Ashwani is going to write.
Achha, the timing.
Yeah, yes, timing is very, very important. And they are the ones which are providing guidelines to the clinicians. So let me pass on this question to our,
Sometimes the guidelines
standard
are wrong also.
PSM,
So the first visit is in the first trimester, less than 12 week, which is for early registration. So that's why some book and some people, they say 3+1 visit or 7+1, but it's better to write it, include it as a visit. The second visit is 14 to 26 week. Third visit is between 28 to 34 week, and fourth visit is between 36 to 38 week. So how to remember it? Very simple. Every time you can see the gap is of 2 week. The gap between any 2 visit is of 2 week. And then we start with 12. 14 to 26 is also 12 gap. 28 to 34 is 6. So 12 divided by 6 will be 2 week, and 2 week is this 36 to 38. So this is the 4 visit. If in the question, if nothing is written, that whether it is WHO or Indian guideline, nothing is written and they just ask minimum visit. So always you have to answer 4. Don't write 8 unless WHO is given in the question.
And WHO has a suggestion. In India, even people, the pregnant ladies, I'm not talking about those who are, visiting the hospitals. There, the recommendation is, around, 10, 12 visits or 12 to 14 visit comes if they are ideally following that. Okay. So it is first visit in the first trimester, second visit in the second trimester, and third and fourth visits in the third trimester. So total 4 visits. Fine.
Of course, one more thing I would like to add is that there are 4 tests which is done during every ANC visit. And out of these 4 tests, one is the hemoglobin measurement, not by Sahli's method anymore. We use digital HemoQ machine. to measure it. Second is, of course, we will measure the weight. Third, we will measure the BP. And fourth, we will measure the urine protein and sugar.
Albumin sugar.
Urine protein or albumin and urine sugar. And this urine albumin and urine sugar is tested by dipstick test. We give the dipstick with 2 litmus and then we check the color of the dipstick with the color of the box and we diagnose proteinuria, which can suggest preeclampsia.
Now, why this is important to measure the weight and the BP of the patient? Okay, every visit, this is must. Weight is important, number one. It is according to the dates, the patient's weight is growing so that the growth of the baby is adequate and to diagnose or to pick up IUGR. Number two, why weight is important? Because very, very important in primary gravida. The PIH, incidence of pregnancy-induced hypertension, is very, very common in primary. 10% of the females come out to be pregnancy-induced hypertension or preeclampsia or gestational hypertension. And multigravida, it is 5%. So, if earlier we diagnose it, weight is one criteria, BP is one criteria, although the main important criteria, gestational hypertension, the BP rise more than 140 or 90 or equal to 140 by 90 occurring after 20 weeks of pregnancy. If the blood pressure rise is present from the beginning of pregnancy or less than 20 weeks, it is chronic hypertension, it is not PIH. Okay. Number two, although BP plus proteinuria is preeclampsia, but when we want to differentiate mild preeclampsia from a severe preeclampsia, then proteinuria has no value. It is the end organ disease. So it will be discussed in, like my upcoming session of high yield questions for upcoming exams. Okay. So why this criteria according to PSM? At least we can have a coverage or we can go for a minimum investigations, and that should be given to all the pregnant females who are attending the clinic. Hemoglobin is very important because, like anemia incidence in pregnancy in our country, if you take the Government of India standard as less than 10 gram percent, the incidence is very alarming. 60 to 70% of the pregnant females are anemic. If you take cutoff value which WHO has given less than 11 gram percent, incidence of anemia in our country in pregnancy will be 100%. So, we have kept the standard at till 10 gram. Why don't we go below the 10 gram? Why can't we take it 9 gram? The reason is till 10 gram we call it as physiological anemia of pregnancy because of hemodilution of blood. So weight, BP, hemoglobin, urine albumin, sugar are minimum 4 checkups that is being done.
Okay. Plus there is one more question, that what are the other investigation which is available at sub-center? So total there are 10 investigation. And they have asked this question that do we do fasting blood sugar or random blood sugar? So at sub-center we do random blood sugar because it's difficult for villager to maintain 5-6 hours of fasting. Villagers sometimes wake up at 3-4
And it is not routinely recommended for a pregnant lady as well.
Yes, it is done between 20 to 28 week of period of gestation for gestational diabetes.
Yeah, it is 24 to 28.
In national guideline, this is the range they have
So
used.
according to the DIPSI criteria, that is diabetes in pregnancy study group, like the, best screening test universal that should be offered to all pregnant females is, glucose challenge test, where irrespective of the fasting status, we call the pregnant lady, and ideal time is 24 to 28 weeks. Why we are doing it this time? This is very important question in gynae. That is the insulin resistance is very high at this time because of the hormones. Okay. So what we give it, 75 grams of glucose, and we take the blood sugar after 2 hours. Cutoff value is less than 140. This is very, very important. Incidence of diabetes in pregnancy is very high in India.
Okay.
Okay.
This question was there in NEET exam also, that the RDT kit which is rich in histidine protein. Histidine protein rich kit is used for Plasmodium falciparum, and if it is Plasmodium falciparum and Vivax both, then we use optimal kit, and in the optimal kit we have the enzyme lactate dehydrogenase. So lactate dehydrogenase enzyme can detect both falciparum and Vivax, but remember histidine rich is for falciparum. So these are the 3 tests plus the above earlier 4 tests which even ASA have and even ASA can do. Then there are 3 star tests, which is HIV test, hepatitis B test, and VDRL for syphilis. Why these are star? Because they are in air, not in ground. They are mostly in the theory, not in reality, which is present at subcenter. So total 10 tests are there at subcenter. And then there is total 15 tests which is there at PHC, out of which 10 is this 10 which we have written. And then there are 5 extra tests which is at PHC, 5 extra tests. So they have asked that which of the following test is not present at PHC. Option are liver function test, ZN smear, malaria slide examination, or the ZN smear, malaria slide examination, LFT, or CBC blood, which is not available at PHC. Can you answer it? Please try to answer it. So one test which we have, which is again a star test, is hepatitis C test at subcenter. This is the 11th number of test. The second test is the CBC blood, because at PHC we have a microscope and a lab technician, so they can diagnose CBC and platelet count and all. Then we have the malaria slide examination, the same slide which is prepared by MPW, multi-purpose worker, by active surveillance. Active surveillance means they will go into the village once every 14 days and they will search for hidden cases of malaria. So by active surveillance, they detect malaria at subcenter and then they send the slide to PHC. If you have Plasmodium falciparum, the gametocyte will look like banana-shaped gametocyte. If this is the RBC, then the gametocyte will be banana-shaped. And very commonly asked image-based question is from here, so I am taking the extra time, ma'am. So
no, that's okay. That's really fine, because it is adding, knowledge to us also.
Yes. Thank you so much, ma'am. And this Vivex part, they will ask, then they will give multiple granules inside it. So if you find a dotted RBC with nucleus, many students, they think that this is nucleus, so they take nucleus as banana-shaped gametocyte. No, if there is granules inside the RBC, that is Vivex part. If it is only banana-shaped without granules, then it is falciparum, and sometimes the banana-shaped can come outside the RBC also. Along with that, the 2 other tests are ZN smear and malaria slide ZN smear, malaria slide examination, CBC blood, hepatitis C. One more thing which is there, liver function test is not there. Monk, Dr. Subham Gupta, Jatvik Sojitra, they all are right. Very good. Now, one more test is there at PSC. Can you guess which one more test which I am missing here? CBC blood, ZN smear, malaria slide examination, hepatitis C, and one more microscopic thing which we do at PHC. What is this extra test? I am also missing it actually. Under the pressure, I forgot it actually. Okay, but I think it will come back to my mind.
Let's take up next question.
Next question. Okay.
Okay, we'll come back to this question. You also think and we also think.
Yeah,
not me.
I will also try to read.
Yeah, Dr. Ashwani will think about it, because I don't know the answer for this. Let me be very, very clear.
The last test is urine routine and microscopy.
I think he has written TFT.
No, urine routine and microscopy. Because the lab technician can do the detection of albumin and all in urine sample
but
directly.
Not microscopy.
This is microscopy which is here. At PHC, microscope is available. So at PHC, they can do microscopy, but at subcenter, no microscope lab technician. So at subcenter, we use the dipstick test for detecting urine. So that was the dipstick test at subcenter. This is for subcenter. So these are the 10 tests of subcenter and 15 tests of PHC. I hope you will remember it.
We have taken up that, and let us take up something from the topic of contraception, which is very, very important and overlapping or integrated questions of OBS and Gynae and PSM. Contraception is one. So we have kept many questions on this. Now, which of the following are important history we should take while considering a copper T insertion, except which is not important? Acute PID, ectopic pregnancy, undiagnosed uterine bleeding, or history of MTPs done in the past, which is not important history. Or you can say 3 of them are absolute contraindications for an IUCD insertion and 1 is not. What is that?
Because
What
I
is
have
that?
seen in last year also they asked in AIMS multiple choice question is also there sometime, and it's very likely that the questions on test, the question of contraindications of contraceptive can come.
And what is the type of IUCD they have given in this question? So it is, what is the type of IUCD that you see? Yes, yes.
Acha, here.
This is, Dr. Ravi Kumar has written it very correctly. History of MTP is not important. Rest all are absolute contraindications of an IUCD insertion. Okay. So this is a Copperty 380A, which is government supply IUCD.
Continue, ma'am.
Government supply IUCD, and its effective period is 10 years.
10 year.
And like failure rate is 0.6 per 100 women year. So you should be knowing this. Now you have kept one more question. What is the most common complication of an IUCD insertion? What's the most common complication of IUCD insertion?
Try to answer ma'am question. This 380 is the area of Copperty in millimeter square.
Surface area.
Surface area in millimeter square. So, what is the most common complication of IUCD insertion?
Yes, Dr. Ravi Kumar is very right.
Again,
Many answers he's giving correctly. It is the
bleeding.
And what is the most common reason for removal of an IUCD? It is pain. Bleeding is not the answer because Copperty takes 2 to 3 months to set in. So a reassurance, hematinics and antibiotics should be given. Why hematinics? Because she is losing blood, the periods are heavy. Number 2, why you need to give antibiotics? Because Copperty is a foreign body and it can be a source of infection. So infection can lead to menorrhagia as well. It will add on. So we are going to treat infection. But if it is persisting, then we might have to remove the IUCD.
Okay.
My friend wants to show some important reference from a standard textbook.
What we are trying to show you is the contraindications of IUCD. Very simple, just this.
All of us know the answer, but he wants to give it a reference so that it should be authentic. Authenticity of the answers are being maintained.
Plus, it's easy to remember. If you just 5 point, you will remember. Of course, in pregnancy, we don't give it. PID and ectopic pregnancy are increased by it, so we don't give it in these 2 cases. Then if there is vaginal bleeding and we don't know the reason, it can be cancer also, so we don't insert it. Then if there is actual cancer of cervix, uterus or adnexa, we don't insert it. And if there is history of previous ectopic, that is, we don't insert it. So PID, ectopic pregnancy, vaginal bleeding of unknown reason, cancer of cervix and pregnancy, we don't insert it. So if they can ask a question, multiple choice question for an ideal IUCD candidate. At least one child should be there, because sometimes the inflammation in the uterine cavity can cause problem in further pregnancy. So they write in PARC.
So this is something which is standard. There is like type 4 IUCD, which is like, what is that? Frameless IUCDs, which are being given to the nulliparous females as well.
Oh.
Yeah, that is Flexigard is one example for that.
Type 4 IUCD.
That is like frameless IUCDs for nulliparous females.
So
nulliparity has become a relative contraindication. That is what I want to emphasize here. Previously, nulliparity was an absolute contraindication. So Flexigard and the frameless IUCD, there is not a frame. So it is just the 6 beads of copper in a polypropylene thread that can be inserted.
Okay, so Flexigard 4th generation IUCD. That's a new information for me also, ma'am.
Okay.
And very good.
So what is the ideal IUCD candidate?
Should not have pelvic disease, should have normal menses like me, should have the ability to check the thread of IUCD. That's why in lunatics or females who cannot check the thread, that's not an ideal candidate. We can give it, but not an ideal.
Monogamous relationship is very, very important, because if there is a multiple sexual partners, which is the best contraceptive for a multiple sexual partners?
Condom.
Of course, it is a barrier contraceptive.
STD will be prevented there.
Okay.
And she had the ability to follow up, that is there. Okay. So these are there. One more question which me and ma'am were discussing before coming is, what is the time of insertion of IUCD, for which the question has also come in this thing in previous NEET exam. They say one time is within 10 day. Second timing is when they call it immediate postpartum insertion, just after delivery. Third time is post-perpural insertion. Post-perpural insertion means after 6 weeks of delivery.
That is, we call it as interval insertion. Interval insertion means after 6 weeks of delivery. Previously, the protocol was after the patient is delivered, she was discharged. We used to call her for after 6 weeks, let the purpurium phase be over. But the compliance of the patient is very poor. Now, the standard which has been followed in most of the hospitals, in the government hospitals as well in India, it is post-placental insertion within 10 minutes of placental delivery. Then it is post-delivery insertion, that is 24 to 48 hours of delivery. Interval insertion, that is after 6 weeks of delivery. And if it is MTP or abortion, it is immediately to be inserted after you take a consent from the patient. And then there is, if she is not a pregnant lady, she has not delivered any child, or she is not an MTP case, then when do you advise insertion? Then as soon as she finishes her periods. Like yesterday she's finished her period, we can call her for an insertion.
Within 10 day anytime.
Yeah, that is very, very important.
Yes.
So insertion is very important. One more question is, there is a female, she comes with a 6 weeks amenorrhea and she has a copper T in situ. What is, and on examination the copper T thread is visible. What is your management? What is your management? 6 weeks amenorrhea and copper T in situ. On examination, copper T thread is visible. What is the ideal answer for this question? This is very favorite question. Very
copper
favorite.
Thread visible, hai na? Thread
Copper
visible.
thread visible.
IUCD thread visible, hai na? Thread visible. What is the thing which you will do now? The thread is visible, and there is 6 week amenorrhea. What will you do?
Dr. Ravi is writing very correctly. Answer is, whenever in the question the thread is visible, always the answer is removal of IUCD.
Now,
And number 2, give the female a choice of MTP. We can't say, let's do MTP. Give her a choice. She wants to continue pregnancy. Copper T is not teratogenic. But why we are removing copper T? Because it is a source of infection. Okay, so we are removing copper T because it is a source of infection. It is not that it is going to cause any teratogenic effect. So give the female a choice of MTP. This is the best answer. If suppose copper T thread is not visible, then what? Then your answer should be, and mostly it is given as 8 weeks amenorrhea, 10 weeks amenorrhea, 16 weeks amenorrhea, copper T in situ, and the thread is not visible. Then your answer is, let her continue the pregnancy, because for a failure of contraception, remember, second trimester MTP is not done, it is risky. Failure of contraception, like a condom rupture or patient forgets to take OCP, the best contraceptive will be emergency contraception for her. Like the condom rupture has occurred. So why we have to wait till she gets amenorrhea? She should immediately come to the doctor and get an emergency contraception, which is postcoital. Postcoital is very, very hot topic for question. What is the most commonly used emergency contraception in India? Is LNG pill, levonorgestrel pill. So postcoital 2 types का होता है, hormonal and IUCD. Hormonal to be given within 72 hours of unprotected coitus, and the most common is LNG pill, which is easily available, 1.5 milligram single dose.
Yeah, that is the question which came from here. What is the dose of progesterone in it? It is 1.5 milligram level.
Single dose, okay? And what are the other hormonal contraception which can be used? OCPs, low dose OCPs, that is 4 and 4 tablets 12 hours apart, and the third is RU486. Now, what is the best emergency contraception? Can you write down in the answer? Best emergency contraception. Best emergency contraception, Dr. Rahul is very correct, is IUCD. All IUCDs can be given? No, only copper T. Mirena or hormone releasing IUCD is not proven. So it is to be given within 5 days of unprotected coitus. Why the answer is copper T? Why the answer is copper T? Because this act of coitus has led to fertilization or not, we don't know. Even if the fertilization has occurred, the mechanism of action of IUCDs prevents implantation. But simultaneously, mind it, no protection against ectopic pregnancy. So whenever a patient comes with amenorrhea copperty in situ, if you have to select urine pregnancy test or an ultrasound, I would say ultrasound will be the better answer, although we do urine pregnancy test. Why ultrasound? Because it rules out the possibility of ectopic pregnancy before it ruptures and patient faints.
Okay.
So this is very important. Can you tell me any other hormonal emergency contraception not available in India, but it is used worldwide outside? That is ulipristal.
Ulipristal.
30 milligram within 5 days of unprotected coitus. What is ulipristal? Ulipristal is selective progesterone receptor modulator. इसके दो ही uses हैं, emergency contraception and to shrink the fibroid.
Okay. Ulipristal 30 mg.
Ulipristal.
And the dose of RU486 is 10 milligram. 10 milligram. And within 72 hours.
Ulipristal is within 5 days of unprotected coitus, and it is selective progesterone receptor modulator, and its other use is in fibroid. 6 months it is given in fibroid, it leads to shrinkage. Okay.
One question has came in PSM, ma'am. I would like to ask it from you also. Question was, does ASA distribute condom? Yes or no? Was like multiple work of ASA was given. One work, which of the following is not a work of ASA, they write. है ना? Not a work of ASA. And similarly, they can also ask ASA or Anganwadi worker also like that. है ना? So which is not a work of ASA or Anganwadi worker? Option A was C, distribute condom. Option B was that C, give vaccine. Option C was C, conduct delivery. And option D was C, make malaria slide. Actually, it is a multiple choice question. Multiple options can be correct. So, which is not a work of ASA if they ask?
Conduct delivery is not a work.
Conduct delivery is definitely not a work. Even giving vaccine is not a work. Making malaria slide is also not a work. These all
Because
three.
she can distribute condoms, because you know, like, contraceptive coverage is very important, because we are in the list of highest population in the world. What is the number? Are we number 2 or we are reaching number 1?
Almost close to number 1 now, because China population is declining now. There are more deaths in China than the births. So
And which country the population is, you know, like, declining more? Japan, I have heard.
Japan is really declining fast, and India will also decline after around 10 years. It will definitely decline. Right now, we are in a stable condition. The total fertility rate of India is already 2.1.
Okay, very good.
This is the target of India also. They ask it that what is the target? Because we want hum do hamare do, me too, our too. But to achieve 2 child, we need to produce 2.1 child. Because out of 2.1, some will die also. So the target of producing children per female is 2. That is TFR. How many children per female? So the target is 2.1, so that we achieve 2 child per couple. And this 2 child per couple is achieved if the net reproduction rate is equal to 1. Net reproduction rate is the number of female child surviving per female. And if one female child is surviving, considering the child mortality rate, we count that how many child are surviving. So if one girl child is surviving, then we can assume that one boy child is also surviving somewhere. So the total become 2. And if we want to achieve NRR of 1, then we need a couple protection rate of 60%. Let's say someone
very correctly,
from you.
Dr. Shubham Gupta is writing. I can see the answer.
Very good, Shubham Gupta. Shubham, suppose, became the medical officer in charge of a village. So, of course, he will try to give contraceptive to all the couple, but not all the couple will take contraceptive. Some want children, some are not in mood or capability to have sex, some are pregnant. So, even if Shubham Gupta, let's say, gave contraceptive to 60% couple, then the population will have less unwanted children, and there will be 2 child per couple. So do remember this point, very correct. And do remember that these 3 are not a work of ASA. We already have discussed that making malaria slide is a work of MPW. By which type of surveillance they make the slide? Passive or active or sentinel? That is your question. if you have heard the discussion or you know it, you can answer it. Which type of surveillance they do to make malaria slide? Because they are going into house and searching for hidden case. So that is active surveillance. And passive surveillance is notified case which are coming to hospital themselves. And if you add active and passive, that becomes sentinel surveillance. So sentinel surveillance is for all case, active for hidden, passive for notified case. Okay. So coming back to one question which is there. Yes, this is the question.
Yeah, which of the following is an absolute contraindication of OCP? Diabetes, obesity, hypertension, impaired liver function. Now let us see what do you mark in this question,
Very good.
which is an absolute contraindication. This is something which is important.
Oh, very good. Ravi Kumar has again answered it first. D is the answer which he had written.
Yes.
Multiple D.
I like that D. कि भाई सुन लो, यही आंसर है.
Very good.
So because diabetes, obesity, hypertension is a relative contraindication. Okay. Absolute is uncontrolled diabetes or diabetes with complications. Okay. Hypertension is severe hypertension more than 160 by 110. Impaired liver function, active hepatitis, hepatic adenoma, hepatocellular carcinoma are all contraindications to the use of OCPs, and all these are absolute contraindication.
Dr. Jen Mode has written that his nice discussion is going on, loving it. Thank you, Dr. Jen.
Yeah.
Love you too.
Even I would like to take the compliment from Dr. Ravi Kumar. He's written it very, very correctly. Okay. Chalo. Let's
Ravi is written it right again and again. So let's quickly revise again that same 5 point. What are the contraindications of OCP and what are the beneficial effects of OCP? Let's first focus on the contraindication. Park has recent edition of Park. All these photos has been taken. Cancer of breast is also written here, along with cancer of breast genital tract cancer. That means breast and cervical cancer. These are the two cancer where OCP is contraindicated absolutely. Then
no, it is like endometrial cancer.
Of course. We can remember it like this, that O for OCP, O for outside cancer. So OCP is increasing the outside cancers, and of course cervix is not outside but comparatively out as compared to uterus and ovary. So correct me ma'am if I am wrong, but we have read that uterus and ovary which are inside, these two cancers are being decreased by OCP, and breast and cervix which is comparatively outside are being increased by it. And
increases the risk of adenocarcinoma cervix.
Adenocarcinoma.
Most common cancer is a squamous cell carcinoma.
Okay, that is why
one more thing is you should know
from gynae person. Adenocarcinoma is increased, squamous cell is decreased. Very
okay,
good.
and one more thing, it reduces the incidence of colorectal cancer. It also protects from PID. It also, there are so many uses like menorrhagia, menstrual disorders, premenstrual syndrome, okay, and autoimmune disorders. Why it is protective against autoimmune disorders? Because it is steroids.
Oh yeah.
That is the reason.
Yeah.
Okay. One more thing. Now, if there is a history of H-mole or a choriocarcinoma, and we have given the treatment, like in choriocarcinoma, chemotherapy is the treatment of choice, multi-drug or single agent. Now, if she is a high risk and she needs to be follow up for continuous 2 years, every monthly the beta HCG should be negative. Okay. She should not become pregnant because we will not be able to understand this beta HCG is a recurrence of the tumor or it is from the pregnancy. So she should use contraception, which is a choice of contraception in choriocarcinoma trophoblastic tumor follow-up. Previously the answer is barrier, now it is OCPs because the failure rate of OCP is just 0.1 if used perfectly. This is very, very important. I wanted to add on. Okay. Can OCPs be used in the hirsutism case or PCOD cases? Yes. Because it increases the sex hormone binding globulin. So free testosterone gets bind, and hirsutism and other features of hyperandrogenism gets protected.
Oh.
Okay. So we need to coordinate
Yeah,
from the
very good.
gynae as well as from
Yeah,
the
because PSM
PSM
just
point of-
teach the bare minimum, and ma'am was adding the part from which question are coming. So do revise and listen it again if it is not yet in your
And
mind
one
yet,
thing I
right?
wanted to add on before I forget it, like there are guidelines if the patient cannot come. We want to cover a larger population. Then the community medicine, they have given us the guidelines, or the health personnel of the government of India or the WHO has given us a guideline. At least in the reproductive span of the female, do at least 2 pap smear. One is at 35 years of age and one is 45.
Yeah.
रूटीनली हमें वही करना है 21 to 65, बट अगर हमें लार्जर पॉपुलेशन या फिर वी द हेल्थ फैसिलिटीज कैन नॉट रीच और द पर्सनस कंप्लायंस इज पुअर, एटलीस्ट 2 टाइम तो स्क्रीन करो. व्हाट इज दैट एज ग्रुप इज, one is 35 and another one is 45. You can add on and continue. You were
Yeah, sure.
discussing about OCPs.
Yeah, of course. They have written cancer of breast, liver disease, previous history of disseminated
Thromboembolism.
intravascular coagulation or thromboembolism, congenital hyperlipidemia, they have written as absolute
If it is
contraindication.
just hyperlipidemia, that is relative. If it is congenital, then it is absolute contraindication. That is very important point to be noted here. Because main they don't ask. They want to twist the question so they can ask congenital hyperlipidemia. If congenital hyperlipidemia is written, it is absolute. If it is written hyperlipidemia, then it is relative.
Relative.
Okay.
And of course, if they ask you the benefit of using OCP, what are the extra use, then ma'am was telling it before starting session. I think she can brief it very well.
That it eliminates the possibility of ectopic pregnancy. Why? Because no ovulation, no chance of ectopic pregnancy. It corrects anemia because it causes endometrial atrophy. Then protection against benign breast diseases, protection from ovarian cyst, ovarian cancer, protection against endometrial cancer, protection against colorectal cancer, protection against trophoblastic tumors and choriocarcinoma. This is among the cancers. And then, like autoimmune disorders and all, as I said. And, other benefits are in menstrual disturbance, this is the contraceptive of choice. Then in premenstrual syndrome, then in cases of dysmenorrhea, etc., PCOD, hirsutism, acne, all these things.
So that is the summary part of the benefit and the contraindications.
We really
Please.
like your compliment, Dr. Ravi Kumar. Thank you very much for appreciating both of us. Okay.
Very
So we need to improve upon further knowledge if our efforts are being appreciated.
Yeah, definitely.
So this is again a very latest question, and again this question has been repeated. It was asked in INI-CET, and again this time also they have asked this question. So which of the following is not indicated in first trimester abortion MVA? Is manual vacuum aspiration, DNC, mifepristone and misoprostol, installation of ethacridine into amniotic cavity. Where the facilities, that is in the rural area of electricity is not available, there is manual vacuum aspiration is being used. And how to identify it? It has a 2 valve system, and the capacity is 60 cc capacity. 60 cc capacity. Okay. Pressure generated by this is 66 millimeters of mercury. So this has been used. This has been used. These are all first trimester MTP methods, and this is second trimester. But the best for second trimester MTP is prostaglandins. Best for second trimester is prostaglandins.
Okay, so mifepristone, misoprostol. If suppose someone asks what is the abortifacient of choice or abortion method of choice in first trimester?
See, if it is less than 7 weeks, then abortion can be done by tablets. Okay, less than 7 weeks of pregnancy, abortion can be done by tablets, where tablet mifepristone is 200 milligram oral, and after 48 hours it is tablet misoprostol, that is prostaglandin E1, 400 micrograms oral. This is followed by abortion. If it is 7 to 9 weeks, then it is mifepristone 200 milligram oral, and after 48 hours tablet prostaglandin E1 800 micrograms intravaginal tablet. If they are asking an MTP, suppose it is 10 to 12 weeks or 8 to 12 weeks, then suction evacuation is the best method. Okay, then you should know what are the guidelines for the previously MTP Act. What are the differences? 1971 and new MTP Amendment Act 2020. Implementation has been done in 2021 and 22. Okay. One difference is this is legal up to 20 weeks, and MTP in new Amendment Act, it is legal up to 24 weeks. Number 2, opinion of one doctor was needed when it is MTP by the previous method. Here MTP by the new method, opinion and one doctor when it is less than 20 weeks. But if it is 13 to 20 weeks in the 1971 Act, then opinion of 2 doctors is must. Okay. Whereas latest it is 20 to 24 weeks, 2 doctors opinion is needed. So how many people the doctor can do, how many MTPs he has assisted RMP who can perform MTP independently? So the answer is 25 MTPs. There are lot many considerations in the MTP, so you should be knowing what is the difference in the new Amendment Act. Okay. Now why there was need to change this MTP Act? Because the special cases like the rape victims, like the unmarried, okay, like some congenital anomalies which are detected by ultrasound or the echo, and it has crossed like 20 weeks, then there was some need in the amendment, because these cases they had to continue the pregnancy. But now according to the latest, this should be considered for MTP if it is a rape victim, or if a lady is coming with a ultrasound report or targeted ultrasound report which is showing that it is some severe congenital anomaly which cannot be compatible with life, like fetal echo is most of the time done 24 weeks, past 24 weeks. Okay. So if suppose a rape victim comes and period of gestation is 25 or 26 weeks, should we consider it for an MTP? Then that is a special case and it goes to the medical board, which consists of a gynecologist, a pediatrician, a radiologist, and a gazetted officer appointed by the government. And it is this board which decides that yes, termination of pregnancy should be considered on this like social grounds, because rape is a social ground, is a social indication. Okay.
So there is a question by Kishore Kumar, that is ultrasound mandatory before medical abortion in India? I think it is mandatory, because to rule out ectopic pregnancy we should do ultrasound before doing it. But ma'am, is ultrasound mandatory before medical abortion in India?
No, we can straight away give abortifacient tablets if there is any suspicious that of an ectopic pregnancy. It can be done, but ultrasound is not mandatory.
Oh, ultrasound is
Okay,
not
we can
mandatory.
write abortifacient tablet.
Okay. And now let's go to the next question. One last question is that this you have written till less than 7 week mifepristone plus prostaglandin. Both are being given,
But
or
this
only
is oral. This is oral regime now.
Oral regime.
7 to 9 weeks if you're doing, then misoprostol is intravaginal tablet. That is what is the difference.
Okay.
And
Oral
the
regime.
dose is increased now, 800 micrograms.
400
It was 400. Okay.
Very good. Chalo. Now, next, the question is of 37-year-old female who come to family planning clinic asking for contraceptive advice. She delivered the child 3 weeks ago. She is P2L2. She has hypertension, and she is interested in combined OCP or spacing contraceptive. What will be your advice to her? So try to give advice to her. Of course, ma'am will give the correct advice.
If suppose I will just remove this.
This word has to be removed.
Actually, we have written in the explanation. Okay.
That was the explanation part. That OCP cannot be given. Of course, we can give the progesterone
Why
only
can't you
pill.
give OCPs? Because in less than 6 weeks, OCPs are absolutely contraindicated because it reduces the breast milk. And from 6 weeks to 6 months, it is relatively contraindicated. It is the estrogen component which reduces the breast milk. Okay. So, what is your answer to this question? Subdermal implants, OCPs exclusively breastfeed the child because it suppresses, like it leads to lactational amenorrhea. So, for 1.5 years, we should promote lactation safely for a method of contraception or antra. What is antra? It is DMPA injection. Now, what is your answer to this question?
What is the advice which you will give to this patient?
Yes, Dr. Shubham has written very correctly, in the lactating mother, progesterone only pills is the best. But my dear friends,
That is not an
progesterone
option.
only pills is not given in the option.
Then what you will choose?
Then what will you select? Not even IUCD is given in the option. Arey वाह यार छा गए.
Dr. Gen mode.
Gen
Easy.
mode.
Gen
What is
mode.
your name? I don't know, but
Peaceful Gen mode.
Yes, Shubham Gupta भी correct है. Kishore भी correct है because POP is the choice, progesterone only pills. But spacing के लिए IUCD the best spacing contraceptive. Okay. But यहाँ पे आंसर हम क्या करें? सबडर्मल इम्प्लांट्स कर लेते हैं बिकॉज स्पेसिंग का मतलब हमेशा होता है थोड़ा लॉन्ग ईयर्स के लिए चाहिए यार. शी डज नॉट वांट टू हैव a pregnancy, so subdermal implants is LARC contraceptive, long acting reversible contraceptive. So subdermal implants, IUCDs, they are LARC contraceptive, long acting reversible contraceptive. अंतरा में क्या दिक्कत है? इसको क्यों नहीं दे देते हम? क्योंकि every 3 monthly patient has to come for an injection. ठीक है. Antra, DMPA. The mechanism of action is suppression of ovulation. That is, we are happy. But what is the important side effect? It causes irregular bleeding and it decreases the bone mineral density. तो अगर हम long acting की बात कर रहे हैं तो patient is prone to osteoporosis. तो subdermal implant जो कि इम्प्लेनॉन है और अगर इसका हम रेडियो ओपेक वर्जन देखें तो नेक्स्ट प्लेनॉन है. ठीक है. सो सबडर्मल इम्प्लांट्स, व्हाट इज द एडवांटेज? इट आल्सो हैज अ मैकेनिज्म ऑफ एक्शन सप्रेशन ऑफ ओव्यूलेशन, बट इट हैज एन एडवांटेज दैट इट डू नॉट डिक्रीज बोन मिनरल डेंसिटी, सो प्रोटेक्ट और प्रिवेंट फ्रॉम ऑस्टियोपोरोसिस. ठीक है. बट इरेगुलर ब्लीडिंग इज द साइड इफेक्ट. एक एडवांटेज क्या है इसका? सबडर्मल इम्प्लांट इज फॉर 3 years और इसमें प्रोजेस्ट्रॉन कौन सा है? इटोनॉर्गेस्ट्रॉल. दैट इज अ मेटाबोलाइट ऑफ डेसोगेस्ट्रॉल. इटोनॉर्गेस्ट्रॉल, दैट इज अ मेटाबोलाइट ऑफ डेसोगेस्ट्रॉल. So 68 milligram of etonorgestrol. It is subdermal implant inserted under local anesthesia by an inserter in the arm, subdermal region of arm. So radio opaque क्या है? Next planon. ठीक है. But उसमें composition same है. And what is the failure rate of subdermal implant? 0.05. Advantage? एक तो बोन मिनरल डेंसिटी डिक्रीज नहीं करता. नंबर 2, मैकेनिज्म ऑफ एक्शन सप्रेशन ऑफ ओव्यूलेशन इन 90% केसेस. तो हमें और क्या चाहिए? लॉन्ग एक्टिंग भी है. 3 years इसका जो है इफेक्टिव पीरियड है. ठीक है. एक बार इंसर्ट कराया, शी कैन फॉरगेट इट 3 years. एंड रिवर्ट ऑफ फर्टिलिटी इज गुड when she wants to remove it. Okay, so that is again an advantage.
You were about to write the failure rate of the contraceptives.
Point 1, this is per 100 women year. Progesterone only pill now they are very good, so it is between 0.5 to 2 per 100 women year. Like combined vaginal ring, it is 0.3. Okay. So, like DMPA injection 0.3, then subdermal implants 0.05, LNG IUCD 0.2, copper IUCD 0.6, okay, and this combined patch, like we have to check it, it is almost less than 0.5. Okay. So this is some of the important failure rates of various contraceptive methods that you should be knowing.
So one more thing is that progesterone only pill uh, is something which we can give till 6 week. Means after 6 week, if the breastfeeding is not exclusive. If not exclusive breastfeeding, then we can start it after 6 week. Till 6 week, of course, no chance of pregnancy, so not needed. And if mother is not exclusively breastfeeding, then we can start it. If not exclusive breastfeeding, then we can start after 6 week. And if mother is exclusively breastfeeding, exclusive breastfeeding means there should be no top milk, no powder milk, no outside milk other than mother milk, and there should be no water. That is, and plus there should be no prelacteal fluid before colostrum. So if there is exclusive breastfeeding present, then we can wait till 3 month or 3 month means around 12 week. But most of the cases there is no exclusive breastfeeding. Like all the cases of C-section, most of the time, of course, we should start breastfeeding as early as possible, but they can start top milk and all. So in that case, after 6 week, we can start progesterone only pill as most early is 6 week. And now let's look at some of the images of the various contraceptives. Ma'am has collected the images for discussion.
This is Mala N. This is free of cost government supply. And what is the type of iron present in that? That is ferrous fumarate.
Fumarate.
Now we say that like OCPs reduce anemia chances because it causes endometrial atrophy. Then why we are adding iron? Number one, because patient has to take 21 days hormone 1 week off. But many of the females, if we are giving OCP, they are village females. So she does not remember when to take, when to stop. तो भाई सारे दिन ही खाओ 21 days hormone 7 iron 21 days hormone 7 iron, so she is taking it continuously, and moreover iron you are adding, it will correct anemia if she is already having pre-existing. ठीक है. Antra is again available in the government supply, that is DMPA injection,
and its dose is 150 milligram.
Every 3 monthly.
We give it for 3 month, dose is 150 milligram. So Dampa name is Antara because Antara means to keep difference between children. So we can use it, but short acting only.
This is vaginal ring, Nova vaginal ring. It is patient has to buy it. It is 3 weeks insertion in the vagina and 1 week off. 1 week off is the menstruation time. Okay. This is Implanon.
Okay.
And this is what previously was Saheli. Non-steroidal anti-inflammatory drugs. Now, non-steroidal contraceptive drugs, sorry. So, is it given? But because Chaya is what is, like, it is contraceptive that is free of cost in the government supply. So, it is famous as a once a week pill. Okay. So, we also don't very commonly prescribe about this, like Chaya Saheli. It is developed in Research Institute of Lucknow that we used to study about Saheli.
So Saheli and Chaya are same. All these are in Mission Parivar Vikash.
But this Nova rings and all.
Nova ring is not there.
And even Implanon is not included.
So if you will talk about Mission Parivar Vikas, this is the family planning mission which government of India have. In the logo, you will find many people holding hand together. That is the logo of Mission Parivar Vikash. Parivar means family, Vikas means development. Under it, government is promoting Antara, not Santara. This Antara is the Dampa. Then there is the Chaya. C for Chaya, C for Centchromane. So this is the Centchromane tablet about which ma'am is telling that it is Saheli earlier, now they call it Chaya. And as ma'am was saying, it is given once a week, but it is given once a week after 3 months.
Yeah, पहले twice a week for 3 months,
Ah.
then once in a week.
Yes, very correct, ma'am. So twice a week in first 3 month, and then it is once a week
pill.
after the 3 month it become once a week. Along with that, of course, government will always promote condom. Government, both male and female, and
Mala
Ah.
N, Mala N, then copper T, copper T 380A, then sterilizations, vasectomy, all these are free.
Preferred. So what is the difference between Mala N and Mala
Any
D?
post-coital contraception which has been added? No.
No new addition there. Just in fact, Ulipristal 30 mg, which ma'am was saying, it was in the previous park edition. They have removed Ulipristal also from the park guideline. So what is the difference between Mala and Mala D? If you were listening, ma'am, carefully, you must have noticed, ma'am told it Mala N is free of cost. Mala D is chargeable. 3 to 5 rupees per strip they charge. Some places 3 rupees, some places
But
5 rupees.
composition is same.
Same composition. What is the composition? The composition of Mala and Mala D both are 0.15 milligram levonorgestrel and 0.03 milligram or 30 microgram of ethinyl estradiol. So this is the composition of a normal OCP, and normal dose OCP example is Mala and Mala D. But if they ask the composition of low dose OCP, only one difference is there. Whether it's normal dose or low dose, both have same levonorgestrel. But the difference is that this ethinyl estradiol, if it is a low dose OCP, then in low dose OCP, the ethinyl estradiol is 20 microgram or 0.02 milligram.
What is that?
So that is low dose OCP. It come in market by name of Familon and all, and because of less
But that
estrogen,
contains, 150 micrograms of desogestrel. That is a higher generation.
Okay.
Because the higher the generation of the progesterone, the side effects are less. जितना potent progesterone आप use करते हो, the side effects are more like gastritis and other side effects. Okay, so side effects are minimized. Okay, there is a generation 4 progesterone pill that is drospirenone.
oh, let me write it
which
down.
is
It's a new
Yamini. Yamini drospirenone.
Dross. Okay, and do remember that the dose of progesterone is 0.15 mg same. Ethinyl estradiol is 20 microgram in low dose, 30 in normal dose. That's the difference between low dose
Fourth
and normal
generation progesterone, and this is Yamini.
dose. Yamini. Yamini
Okay.
Gautam is also an actress.
So, चलो
recently.
अब
Okay.
इनको करते हैं ये. This is important images which has been asked in the latest 2020 exam. What is this?
This is, I hope you all.
Today.
This is the diaphragm or vaginal sponge.
This is vaginal sponge, which is today.
Today, okay. So, never seen it in my life except for the practicals when they keep it. So, this is not diaphragm, this is vaginal sponge. I was writing it wrongly, ma'am corrected me.
Is today.
Today, okay.
Today is a vaginal
Sponge.
It releases a spermicidal agent, nenoxinol.
9.
Nenoxinol 9. But it is not very popular because it, its failure rate is high, 9 to 30. Okay. So the question which was asked, one time it was an image. Number 2, what is a spermicidal agent? Suppose there is a slippage of this contraceptive, then the spermicidal agents are impregnated with it, and female barrier contraceptive is always advised to be used with spermicidal agent because spermicidal agents are surface active agents, okay, which causes dissolution of acrosomal caps. So autolytic enzymes of the sperms are released which can neutralize the sperm. Okay. Now what is the next one? Next one is a female condom, that is Fem Shield. Female condom, that is Fem Shield. Okay.
Okay.
Again, female barrier contraceptive have never gained much of popularity because in comparison, the easily acceptable method among barrier is the male condom. Okay.
Plus, there is higher rate of failure in female condom because if
The
I am
use
a
is not
female, I am
easy.
removing the condom. While removing condom, if there is greater chance of a sperm spillage and therefore there is greater chance of pregnancy. And there is 2 ring made up of polyurethane. But when it comes to the male condom has only 1 ring. It is made up of latex. So if anyone is allergic to latex, then the condom become a problem there. And Do remember that male condom has lesser failure rate. The failure rate is 2 to 1400 women year, and the failure rate of
Average we take it as 2 to 10.
2 to 10 average we
Okay.
can
It
take.
depends upon the perfect use or a typical use.
Yes.
The failure rate is according to that.
According to that. And in female condom, it is 5 to 2100 women a year. So more failure chances in female
And
condom.
one more thing is, whenever you are asked which of the following contraceptive has got maximum failure rate, so don't just jump onto condoms. There may be the spermicidal written in the question, and the failure rate of spermicidal jellies and cream if used alone is nearly 30.
Oh.
Okay. So, like always look at the question and then mark your answer, and just in your mind, just remember what is the failure rate of each contraceptive so that you can mark the correct answer.
And if let's say vaginal sponge or diaphragm is to be more effective, it has to be left in the reproductive tract in the vagina for 6 hours after sex. And if it is left for a very long time, then it can cause septic shock syndrome in some rare cases. And of course, it's very normal for a couple to sleep after having sex. So that's why it become problematic to remove it early, but not too early. And that's why we don't prescribe sponge and diaphragm more commonly. Now, coming on to the question about which ma'am was talking, that which elemental iron we use in Malayan, answer was ferrous fumarate. But what is the dose of ferrous fumarate which is there? The dose is 60 milligram. 60 milligram is the dose of ferrous
elemental
fumarate.
iron.
No, elemental iron is 20 milligram. Ferrous fumarate is
60 milligram.
60 milligram. And if it is 60 milligram, in the 60 milligram, the elemental iron is only 20 milligram.
So what should be answer, 20 or 60?
20 is the answer, because they have asked the question of elemental iron. Whatever is the dose of iron, around 1/3 is the elemental iron. Like in most of the time in earlier days when we used to give 100 milligram iron tablet, then the ferrous sulfate in it was around 330 milligram. So the elemental iron was only 100. So it's 1/3 elemental iron, whatever the compound they give. The problem with ferrous sulfate is can cause more nausea and vomiting. So sometimes we replace ferrous sulfate with ferrous fumarate, which reduces nausea and vomiting also. So here answer should be 20 milligram. So, and of course, you all know the dose of levonorgestrel, which was 0.15. 1.5 is in IPIL, 0.15 here, and ethinyl estradiol is 0.03. Both are in micrograms. Sometimes they write microgram as MCG. That is the same thing. Okay, so do remember it. Coming on to this contraceptive, can you identify it? There is.
But it is no longer used.
Oh, that was a new information for me.
Because what does it contain? It used to contain levonorgestrel.
Yes.
Okay, and effective period was 5 years.
Yes. So Ravi Kumar and Subham Gupta had given the correct answer of previous question. Also 20 milligram was the elemental iron. This is Norplant, and there is 6 Cialistic tube which we insert in the past, now not inserting it.
And this
all
is
of them has
Norplant 1,
levonorgestrel.
because Norplant 2 is 2 Cilastic rods. This is
Oh.
Norplant 1.
Oh.
So actually subdermal implants were of 3 types: Norplant 1, Norplant 2 and Implanon. So more use is Implanon.
Okay, so what is Implanon?
Or like Nexplanon is the radio opaque version, but
Okay.
it contains same thing.
What
Because
is-
whenever
what
we
is the
want to
chemi-
check, we can just get an X-ray done and we can see. Now, what is the radio opaque material in the copper T? Is it copper or is it something else? The answer is barium actually. Barium is radio opaque and copper is for contraceptive.
Okay, because when we read IUCD, in IUCD, there was a first generation IUCD which we don't use anymore. That was
Biologically
Lipley's loop. So initially they covered Lipley's loop with barium also to make it radio opaque. But the problem is that Lipley's loop has very high expulsion rate. So if Lipley's loop is not there, then there can be pregnancy. And in pregnancy, we cannot do X-ray. So even if Lipley's loop is not there, like we cannot detect it by X-ray.
But it is, nowadays nobody asks question on Lipley's loop.
No, not anymore.
Because
It is obsolete. It's outdated.
Outdated.
But they ask question again and again from
Copper releasing
copper
isotope.
to that to also multi-load 375. they give image of multi-load 375 in exams, and it is a bit different from the normal looking OCP. They are teeth-like structure. Oh, ma'am will draw it better, I think. So she was taking the pen that multi-load 375 look like third generation because it is multi-load.
But it contains copper.
It contains copper.
So
it is second generation.
And
This is the
one
correct
more
answer.
thing, it is not freely available. So in the government supply, so patient has to buy it. If she
Oh.
wants an insertion, be done.
Okay, we only used to insert or give copper T380 being available everywhere. So I was not aware of that also. Plus, along with multi-load, if you have Nova T, if you have copper T 200 AG or copper T 380 AG, all are second generation. In these three, the protection time is 4 to 5 year. Here it is 10 year. But when it comes to third generation, as
Marina is 5 years.
Marina is 5 year.
But which type of IUCD you can give in the female who is having menstrual disturbance or suffering from premenstrual syndrome or for endometrial hyperplasia or adenomyosis? The answer is one and only one, Mirena. It reduces the menstrual blood loss up to 97%. So it is a choice. It is an alternative to hysterectomy in many of the females.
Oh,
If they are willing to be on the follow-up.
okay.
So that is something which is important about Mirena.
And as ma'am was saying earlier that the third generation IUCD also decreases ectopic pregnancy chances because as compared to second generation, they have hormone, and hormone is decreasing ovulation as such. So there is less chance of ectopic pregnancy with the third generation because of the hormonal component, and it prevents dysplasia and all those bleeding disorders better. That's good point. And ma'am has
Because
also
you are
discussed.
counteracting the side effects of estrogen. Estrogen causes thick proliferation of the endometrium. Okay. So this, like controls all that.
So now let's come to the sterilization part. In sterilization, when we come to tubectomy and vasectomy, of course, tubectomy is most commonly accepted.
Which is the most important tubectomy method that we follow in India.
Most common, I think it is
There is a
Pomeroy.
postpartum sterilization and there is interval ligation.
Okay.
And we use it mini lap because the small incision. So it is the Pomeroy's technique that is we are using. Okay. And the failure rate of Pomeroy's technique is 0.1 to 0.4%. Most commonly done is Pomeroy's, but other images I've just given if by chance there is a question to identify. So which of the following method the recanalization is not possible, so it is Kroner's. In one of the NEET PG exam question, there was an image of this and they have asked. So that is why I've taken this image to just explain the different types of method. But mostly we are using the Pomeroy's technique. Postpartum sterilization is to be done in 24 to 48 hours of delivery. And interval ligation is after 6 weeks of delivery. Okay? So that is what is an advantage. Number one, एक तो patient हमारे कब्जे में होता है.
Yes, ma'am.
That means the motivation of the patient is high. And number two, she has delivered the child, so uterus is in the abdomen, easier for us to locate the fallopian tubes. So that is what is the advantage of tubectomy.
So interval and other was
Postpartum. So we are doing postpartum if the patient is convinced. Otherwise, she can come for an interval ligation as well.
And Kroner will have no chance of recanalization.
No chance of recanalization. If suppose we want to have a recanalization, suppose unfortunately the husband dies or both her children dies or she has a divorce, she is going for a remarriage, okay, then up to what length of the fallopian tube is left that recanalization is possible? The answer is up to 4 centimeters.
Okay.
Okay. And number two, which part of the fallopian tube is cut in tubectomy? So the answer is isthmic part has been cut. Because if you cut the ampullary part, later on there will not be any chance for recanalization because that is the widest portion of the fallopian tube. This is something which is important.
Okay, what is the most common cause of failure of vasectomy? Why does vasectomy fail? Because the most common cause of failure of tubectomy, ma'am was saying recanalization. And of course that is no doubt. But what is the most common cause of vasectomy failure? That is cutting the wrong wire. Yeah,
there is failure to use a backup method.
they have written it in Park that they misidentify lymphatics or
With vast difference.
they misidentify lymphatics or other component of spermatic cords with vast difference. So that
Is it not a failure to use a backup method?
Okay, yeah, that is what ma'am was saying is, and Park has also written that up to 30 ejaculations
Or for 3 months.
or for 3 months.
The couple has to use the additional method of contraception.
Up to 30 ejaculation, they should use some additional method, and that is also a cause of failure. But Park has mentioned
That this
misidentification.
Ada is writing very correctly. It is wrong identification.
Wrong identification.
I thought it is failure to use a backup method. You know,
That
like,
is, ma'am, you are correct. But data-wise, Park has said that misidentification is more common of lymphatic tubes or other part with vast difference. Okay. So coming on to the next question, this is the laparoscopic sterilization.
laparoscopic sterilization.
About which I know
this
nothing.
is laprocator. This was a question in 2020. Identify. So this is laprocator,
Okay.
and it has a prongs. Prongs to lift the fallopian tube, and what type of material we use to ligate is the silastic rings, which is called as fallope rings. Fallope rings. Okay, and this is carbon dioxide insufflator. Carbon dioxide insufflator, and what is the intra-abdominal pressure is 10 to 12 millimeters of mercury. And how many carbon dioxide should be put? 1 to 2 liters of carbon dioxide. You will have to expand the peritoneal cavity, and somebody or your assistant should elevate the uterus. You can see the fallopian tube. How do you identify the fallopian tube? Is by the femoral end, because the round ligament goes and get attached to the other structures. You will not be able to see the end, whereas fallopian tube identify with the femoral end. Then you release the prongs, they will lift the fallopian tube, and then another button, and you will release the ring onto this fallopian tubes. Make sure that you applied the rings onto the fallopian tube, not on the round ligament. This is important. Wherever you have a confusion, you can always go for a laparotomy. So this is laprocator, and these are the prongs to lift the fallopian tube. Failure rate of laparoscopic sterilization is 0.6%. Your question?
That's a question from demographic bonus. Bonus is always a good news. Sometimes they call demographic bonus also as demographic dividend. So it all depends on one thing that is known as dependency ratio. Dependency ratio simply means that how many population is dependent, and population who are less than 15 year or population who are more than 65 year, they are the dependent population. And as compared to the young earning population, that is between 16 to 64 year, what is their proportion? That is the definition of dependency ratio. So if demographic bonus is a good news, so what is the thing which country want? Does country want to increase dependency ratio or decrease it? Of course, we want less dependency ratio. We want more earning people, less dependent people. Now the question is, how can you decrease dependency ratio? One way of decreasing it, that directly produce children who are between 16 year to 64 year. Not possible.
That is not possible.
Second is kill all those who are old age. If my mom will listen, she will kill me with her slipper only. So again, not possible. So we should not think of it also. And the last option is, let's stop producing children. Let's have less than 15-year people. Then the dependency ratio will be less and country will get demographic bonus. So to get demographic bonus, fertility rate should decrease, because if fertility decreases, dependency ratio decreases, and when dependency ratio decreases, country get demographic bonus. So But this demographic bonus stage will not stay for very long. After 40-60 years, then our population will also become old age and we will lose that. But right now, India is in this phase of demographic bonus. But if we are unable to give employment to those earning population, then the demographic bonus become demographic catastrophe. It become a bad news for the country. So do remember that bonus is
But
obtained.
even I was not aware of all this, and it is adding to my knowledge also.
I learned also a lot of new things. Fourth generation IUCD and a lot of new things.
Okay,
So
that
that's
is what
good
is
news.
good about the interactive sessions.
We also learn things,
Okay.
especially we. So that is quite correct. So that is definitely the correct answer, that demographic bonus, to get it, we should decrease dependency ratio, decrease the dependency ratio. Only C and D can be correct. How can you decrease dependency ratio? By decreasing in fertility. So that is the correct answer. For getting demographic bonus, we should decrease the fertility rate, which will decrease the dependency ratio. Now,
This
we have discussed most common, but still just one point I was willing to say. Most common complication is bleeding, and most pain is the most common cause of removal, as ma'am was saying. So you can remember it, because it can get confusing. You can remember it by the mnemonic PR only, per rectal examination or PR,
Now,
whatever.
here
Pain for removal.
what is one more point here is, if copper has perforated the uterus, what is the management? It is always laparoscopy, oblique laparotomy followed by removal, because it releases copper which attract the WBCs, leading to adhesion, leading to intestinal obstruction. It should be removed by laparoscopy or laparotomy. It should not be left in the peritoneal cavity.
Okay, if it is perforated, you have to remove it. And perforation is most common if it is postpartum IUCD. Then it is most common cause of perforation. Of course, ectopic pregnancy is one thing which IUD increases along with PID. Chalo. And these are just that picture of talking about side effect of it. So it is there. Plus one more thing which we have already discussed, that if IUD is left in the uterine cavity, then what you can do, option A, which is correct of course, if the woman requests an induced abortion, then this is legally available. So we can abort if C is asking, as ma'am was saying. Second, if the woman wishes to continue the pregnancy and thread are visible, then the device should be removed by gently pulling the thread. Third point, if the woman wishes to continue with the pregnancy and the thread is not visible. One time I have seen exam, they have asked this question, that woman want to continue the pregnancy but thread is not visible, what will you do? Then there should be careful examination for possible complication, and if there is any sign of intrauterine infection and sepsis, then evacuation of uterus under broad spectrum antibiotic is mandatory, which ma'am was saying. So if there is any complication, we will screen for complication. If we found, then no matter what mother is requesting, we can go for
Termination of pregnancy.
termination, because the child will have the infection already. So no point of keeping that pregnancy. Okay, so do remember this point being discussed in PAC. One thing which we are talking again and again is about failure rate of contraceptive, which is denoted by two methods. One is Pearl index, other is life table analysis. So if they ask which is the better method, the better method is life table analysis. Because in life table analysis, we don't need a large group of female who are taking contraceptive for longer period of time. But for Pearl index, we need a group of female who are taking it for a very large duration. So what is the definition of Pearl index? They ask what is the formula, and in older time they used to.
We have been discussing so many times.
Yes.
Even everybody knows that formula. Okay. Pearl index is for calculating
failure rate,
contraceptive failure or accidental pregnancies.
Yes. So
But this is something new.
Acha, this life table analysis. Yes.
For me, it is new thing.
Yes. It is rarely used because it will not tell about the group characteristic. It can be used for single female. So in Pearl index, of course, we write the unwanted or accidental pregnancy in the numerator, and along with that, in the denominator, we write total female who are taking it. So total female who are taking it have two components. One is the total female, other is the duration in month. But if you look at the PARC textbook, they have not given this part in the formula. They just write total female taking it. So total female itself has this two component, number of female and for how many months they took it. And then we multiply it with 1200. So ma'am was also saying it again and again that the failure rate of condom, let's say, is 2 to 10, 100 women a year. Why Pearl index measure it in 100 women a year? The reason is that multiplication factor is 1200. in 1200 there is two component. One is 100, so that is for 100 women, and in a year how many months are there? 12 months. So this is why it is 100 women year, because it is multiplied by 1200. And let's say if they said in a question that 10 accidental pregnancy occurred when 100 female are taking a contraceptive for 2 years, what is the Pearl index? So when they say 2 year, you have to convert 2 year into month. That will become 24. So then it will come 5. 10 by 100 into 24 into 1200. So this 1200 0 will cancel out. 24 and 12 will cut by 2, and 2 will cut 10 by 5. It will come 500 women year. This is the only numerical question which come from here. Other than that, and that too also 6 years back, because now they are not giving you pen. But do remember the formula, and do remember better method is life table analysis. Okay. Chalo, coming to the next question. What is the Government of India guideline for sterilization? So, if I want to cut my wires, do I need to take permission of my wife? What do you think, ma'am? Should I need permission of my wife? Huh? Student used to say yes, ma'am is saying no. Okay, if my wife want to go for tubectomy, does she need my permission?
For sterilization, of course, but for MTP, the husband consent is not required.
Not needed. Only
for
in
sterilization it is needed.
Yes, very good, ma'am. Only in case of sterilization. Rest all thing not needed. But in sterilization it is needed because it is irreversible. And that was the question also, irreversible method. So we need permission, that is correct. Female should be below the age of 45 and above the age of 20, of course.
This is also correct.
Correct. Couple should have at least one child whose age is above 1 year unless the sterilization is medically indicated. This is looking like correct, but this is wrong because guidelines say they need to have 2 child, not just 1. So they need 2 child, out of which one should be more than 1 year. Only after 2 child they can go for it. Like let's say second child is just delivered, so within 24-48 hours they can go for the tubectomy, but they need to be 2 child, and they must not have undergone sterilization in the past, otherwise what is the use of doing it, of course. So the correct answer is all A, B, D are there, but C is not correct. Okay, sure. They need 2 child. Now coming on to the question of good obstetric care
is determined most appropriately by which of the following parameter? Good obstetric care. You should read the question very carefully. Is it MMR, that is maternal mortality
Please
rate?
do give answer.
Infant mortality rate, perinatal mortality rate, or neonatal mortality rate? What do you think is the correct answer? Good obstetric care is reflected by which of the following parameters? This is very, very important question, and it has been asked in most of the exams. And students often mark it very wrong.
What is the answer? Yes, ma'am. Continue. Please, you continue. Please, ma'am, you continue.
So, according to me, good obstetric care का मतलब maternal mortality rate से नहीं है. Good obstetric care का मतलब यहाँ पे perinatal mortality से. What does it mean? It means like the fetal death after 28 weeks of pregnancy within 1 week of delivery. ठीक है, still birth हो गया, obstetric care was poor. Okay, baby dying within 1 week of delivery, that obstetric care was not good. Whether it is PIH, IUGR, diabetes, uncontrolled, something or the other. Okay, if it is a 6 months old child dying, then it will come under infant mortality rate. That means pediatric care was not good. Maternal mortality is during the process of delivery or something pregnancy related complication, the lady is dying, and most important reason on preventable cause is a postpartum hemorrhage. That is why there is, like because of the WHO, Government of India, they say active management of 3rd stage of labor. We'll be just discussing that question as well because that is again important. So I would ask my colleague to discuss the numerator as well as denominator, just throw some light on this. So that because this is a very, very important question and it will be overlapping the pediatrics as well.
Yeah. So if you see, let's say this is the 28-week period of gestation and then this is the birth time. So in between that, there will be
any complication
that can cause it. Then this is the first 7 day then this is 28 day, and this is 1 year. So if you are looking at this whole period, birth to 7 day, this is perinatal. The numerator is this. Then if you are looking at birth to first 7 day only, this is early neonatal. If you are looking at birth to
7 day to 28.
birth to
28.
birth to 28 day, that is neonatal, total neonatal. Okay, and if you just look at this component of 7 day to 28 day, that is
Late neonatal.
very good, not post, it is late neonatal. So if you add early and late neonatal, that will become total neonatal. And if it is birth, if it is 28 day to 1 year, then what will you call it? That is not infant death, that is post neonatal. So post neonatal have 28 day to 1 year, and if you add neonatal and post neonatal, this whole will become infant death rate, infant mortality. So they have asked this question also, that which of the following component is not included in IMR? Option are perinatal mortality, early neonatal, late neonatal, post neonatal, which is not included. So perinatal is not completely included in infant death. We only
Because it is from 28 weeks of pregnancy.
Yes.
So whatever we have to calculate about the pediatrics is after the birth, after the baby is born, it is pediatrics. And when is the baby our patient? It is in the obstetrics.
Yeah. So that is the perinatal period around the delivery when they are there.
So perinatal mortality is not included. And just throw some light on the denominator, because this is very, very important.
Denominator of all of these factor is same. That is total live birth.
Or per thousand live birth nahi hai.
Total live birth multiplied by 1000. So definitely, ma'am, you are right. It is per 1000 live birth. They
What
say
about the maternal mortality? They used to say some per lakh.
per lakh. So definitely we will discuss that, the thing. So if suppose I am writing IMR, IMR means death within 1 year, death between birth to 1 year divided by total live birth into 1000. If I ask neonatal, so neonatal, the definition is birth to 28 day, divide by total live birth, multiply by 1000. So these two will remain same in all these factor, only the numerator will change, and we have discussed what are the numerator. Now coming on to the ma'am question of MMR, being very commonly asked again and again. So MMR, they say, is maternal death. Mostly they ask the duration of it. So it is within 6 week or 42 day. And this maternal death within 6 week or 42 day
related to pregnancy and related complications or the process of delivery. So that is what is important. But up to 42 days, that is up to 6 weeks, that is covering the purpurium period.
Yes.
Okay.
And there should be delivery related causes, which ma'am is saying. And it is multiplied by 1 lakh. The reason it is multiplied by 1 lakh is the MMR of India is, let's say, 103 per lakh. So if they multiply it by 1000, then it will become 0.1 per 1000. And if it is
0.1 female is no
government will focus on it. So to make the government focus, they are multiplying it with lakh, bigger factor. And again, it is divided by total live birth. So that is why MMR is not a rate, it is a ratio. Because in ratio, numerator is not a part of denominator. And you can see here, mother are not coming from children. And I did not give birth to my mother. Now my mother gave birth to me. So here numerator is not coming from denominator. That's why it's not rate, it's ratio. In rate, numerator come from denominator. Like infant mortality rate was a rate. Why? Because in IMR, we can see that the death within 1 year is occurring from those who are live birth. So IMR is rate, but MMR is ratio. And do remember the definition and the duration, 6 weeks to 42 days. So if I die after depression, suppose I am a mother, I just delivered and I felt depressed and I went to the rooftop and I jumped from there. So will you count my death as maternal death?
No.
If I am depressed, it can be due to purpural, this postpartum blues, postpartum depression. They count it there.
Okay.
But if I suppose got excited and I put my hand in electric shock and I died due to that, then you count it? No, because that is not delivery related cause. But postpartum depression is a delivery related cause, we will count it there. Okay, so just some question which is there. Now, thank you so much, ma'am, for making me explain this point. Many of the students, when asked what is the most common cause for good delivery practices, they answer IMR. Because IMR was also asked in recent NEET exam, that the question which came in recent NEET was, what is the most sensitive indicator of the available utilization and effectiveness of healthcare? So if they ask utilization and effectiveness of healthcare, IMR is better. Similarly, if they ask best indicator of impact of ASA work, IMR, whether ASA is working or not. If they ask best indicator of health system of country, IMR. Best indicator of female condition in that country is IMR also, because female are mostly dying due to infant are mostly dying due to premature delivery. If female are malnourished, then they will deliver the baby before 37 weeks, and that is the most common reason of death, premature delivery. So female condition, health system effectiveness, impact of ASA work, all three are represented by IMR. But best obstetric care by perinatal mortality, which ma'am said. And then there is this one more thing, child death rate, which include the death after 1 year to 5 years. They will tell us about MCH services. They will tell about the nutrition condition. They will tell us about low coverage of immunization. So child death rate, which do not have live birth as denominator, that include the that will tell us about immunization and other things. Okay, thank you so much. Plus, this was also the question in NEET exam: year of potential life lost. Year of potential life lost means how many year early you died, prematurely you died. That was also one of the NEET question. From this one page, 2 question was being asked. So we already discussed it, which ma'am was kept. Now, just this one small discussion we can have it, because if you are a medical officer at PHC, then which advice will you give to the population? Ferrous sulfate we do suggest, but always ferrous sulfate tablet is with folic acid. And if you are the medical officer in charge, let's say like our friend Subham Gupta, then we can also consider the deficiencies which are occurring due to vitamin B12 deficiencies. And if you add vitamin C, ascorbic acid help in absorption of iron better. So as a MOIC, we should cover all the factors. Therefore, the correct answer is B. Do remember, if they give a history of female who is vegetarian, not eating meat and all, and had some defect in the sensation part and all, it can be subacute combined degeneration due to vitamin B12 deficiency. And of course, vitamin C deficiency lead to bleeding gums and collagen formation defect and all. So we give all the 4 component if we have the opportunity. We never give ferrous sulfate alone. Okay. Now, one more question is that a female has HB of 7.1, her BP is 130/80 normal, and she is at 26 week of pregnancy. What will you give? So for this, we have to look at the guideline of Anemia Mukt Bharat. Anemia Mukt Bharat says that mild anemia is between mild anemia, moderate anemia, and severe anemia is 3 things which they have. Severe anemia, if it is less than 7, okay, less than 7. Moderate anemia,
7 to 10.
Moderate anemia is 7 to 9.9, and mild anemia is 10 to 11 part.
11.
So in mild and moderate anemia, we always treat with iron folic acid tablet, and we never give it 3 in a day. We only give it BD for treatment twice a day, of course, not the BD. And this is to be given from
Second trimester, third trimester, and in lactation.
yes. So 180 day before delivery, 180 day after delivery.
What about severe anemia?
Now, in this case, if let's say the female cannot tolerate iron tablet,
Then injectable can be given.
yes, then we can go for injectable if she is not tolerating, or if she came very late in pregnancy. So these 2 conditions you have to remember: not tolerating iron, IFA, or very late in pregnancy. So in both case, we can go for either IV iron sucrose or IV iron sucrose, or there is ferric hydroxycarbonate, one more component which is like iron sucrose, FCM, which we can use. But in case of severe anemia, we can directly go for blood transfusion. And do remember that we never give iron plus IV iron sucrose. It should not continue together. Either of the one thing we can give. Of course, ma'am know it better for the treatment part, but I got into the excited mode and carried it away because
That's
of the
fine.
guideline of anemia.
But you know, like if it is coming late in pregnancy where we don't have time to build up the iron because iron stores or even the iron, or we need to correct it, at least we have to bring the like hemoglobin level to 10 gram. Okay, even by giving one blood transfusion, the rate of rise of hemoglobin is 1 gram per second. Okay, just remember it. And these patients are more prone to develop postpartum hemorrhage. So as near as possible, we should build up the hemoglobin. If she's coming very late in pregnancy, for example, 36 weeks of pregnancy, these patients have a tendency for preterm labor pains as well, going into postpartum hemorrhage because tone of the uterus is like less in them. So there is a chance of atonic PPH. So preferred is giving blood transfusion. And like best is in severe anemia, we should give the packed cell volume. Okay, if there is no time for you to like, or the lab is taking time or the blood bank is taking time, then you can hang the blood bank back and let the RBCs settle down, transfuse only RBCs and discard the plasma. Or if you want to give that blood, whole blood, then give 20 milligram of Lasix, that is like the diuretic, so that you can prevent the congestive cardiac
failure. Wow. That's just the guideline which I was talking about.
Okay.
This is the next question. There is a fifth, ma'am has created this question, so let's
So we
go
have
with
already discussed
the
this.
MTP Act, but let's go into a bit.
We have
again.
already discussed that if there is a 15-year-old female, she is a victim of rape and it is pregnancy 24 plus 4 weeks, should termination be considered? This case can be like sent for the medical board and they should quickly give the report, and termination of pregnancy can be done according to the latest amendment MTP Act, because this act has been made for these special cases which comes under this, like rape victims, or it is unmarried girl, or it is like female with congenitally malformed fetus where the anomaly was detected late by fetal echo, something like the ventricle was single or something like that, multiple congenital anomaly which is not compatible with life.
So it is, we can continue with that. Like even if it is 24 plus 4, we will go with termination.
There is a special medical board that I said, gynecologist, pediatrician, radiologist, and a gazetted officer appointed by the state government. Upon their recommendation, we can just send. And like other differences between the latest 2020 Act and the 1971 Act, we have already discussed. This is the medical board which I have just mentioning.
So what it all consists? Gynae, radio,
pediatrician, and one gazetted officer. That is
all four should be there.
This is like
multiple choice.
No, this is all is the board.
Acha, medical board consists of
this is 4 people. It is not the multiple
choice
question. It was not a multiple choice question. Okay. Now this is, we are ending up with this question. This is very, very important. All of the following are the steps included in the active management of third stage of labor, except. So take it as an INI-CET question for a practice question, and there can be more than one option. Okay.
More options, more than one can also be. Okay, let me think. Active stage.
Early cord clamping, use of oxytocin, uterine massage, placental delivery by controlled cord traction. So
control cord we do. No. Control cord traction we do.
So Dr. Ashwani is trying to tell me. Okay.
Yes. I'm just trying to confirm I am right or not.
Okay. What are your
Cord-
answers?
What is your answer? Try to
Yes,
answer.
he said Dr. Ravi is writing
Ah.
late cord clamping. What
we
else?
should not do early. We should do it late.
Uterine massage, late cord clamping. These are the both answers. We have to go for late cord clamping.
Not early.
Late cord clamping means cord clamping is done within 1 to 3 minutes of delivery because it transfers around 80 to 100 ml of blood from mother to, okay.
Okay, so
Now,
we don't do uterine massage, ma'am.
uterine massage
Because
is
I
a
remember we
part
used to do it.
part of
After
atonic PPH.
atonic PPH cases. we
Now
used to
it
do.
is a part of atonic PPH
Okay.
management. So it is no longer a part of third stage active management.
Okay.
So active management of third stage of labor is use of uterotonic, and the first choice is oxytocin intramuscular bolus because onset of action is fast and it is very cheap drug, easily available, okay. But IV should not be given because it can cause rupture uterus, so it is intramuscular which is being preferred. Then like delayed cord clamping, and number 3 is delivery of the placenta by controlled cord traction. So these are the 3 which is included in the active management of third stage of labor, and aim is to prevent postpartum hemorrhage because the most common cause of maternal mortality in India is postpartum hemorrhage, and indirect cause of maternal mortality in India is anemia.
Anemia. That is second cause. First is PPH, and within PPH, most common cause is, as ma'am was saying, atonic uterus. Second is retained product of placenta, retained placenta.
I know it's a long session, but I hope you have enjoyed the session and it must have added up or clarified your doubts, because there is many more questions which can be asked in the integrated form. But whatever, these are the topics: cancer cervix, the MTP Act, the PPH, the like preventive obstetrics, the contraception, all these, and there can be many more. We will be bringing some more exciting sessions, okay. So that's all from today, and hope you enjoyed the session and keep revising your syllabus.
Hasta la vista, das vidania. Keep enjoying your life. We will meet again. Bye bye. Thank you so much. Bye bye. Was really good, ma'am. Any session for INI-CET हो गया. भाई ये क्या हो रहा था, ये घूम ही रहा था, क्या हो रहा था?
ये तुम्हारा
Was it coming well?
चल रहा है.